Hello and welcome. This conversation is from a recent interview I had with Dr. David Hanscom. He was a spinal surgeon who now no longer does spinal surgery. In fact, he believes that most operations for back pain are a waste of time. He explained to me, for example, that there is no evidence that disc degeneration in the back causes back pain. Instead, these days he helps people to understand how pain is created in the body, and he has created the DOC Journey, which is an online course which helps people to heal their back pain through a process he's developed, which he'll explain more about in this conversation. But it starts with awareness, so understanding how back pain is created, and then moving through a process of hope, forgiveness, and play. And the overall aim is to reduce anxiety and inflammation in the body. He's been on his own journey with pain and anxiety and panic attacks himself. He's very open and honest about that. So I'm sure you're going to really get lots from this interview. He's a fascinating guy. He gave me plenty of food for thought. So let's get on with the interview.
For me, I went into a panic attack in 1990. I didn't know how I went from a fearless surgeon to a panic attack. And then, I treated it psychologically. I actually went to a psychotherapist once or twice a week for over 15 years. That's a lot of psychotherapy. And
Mm-hmm.
things got way worse. And I didn't know about neuroplasticity. I didn't know about anxiety being the response to a threat, not the cause. I thought anxiety was the threat. And again, anxiety is the result of a threat. And I think you've seen my writings enough to know how I think that this unconscious survival response is so much more powerful than the conscious brain. Have you seen that part of the
Yeah,
work?
yeah,
Okay.
yeah.
So what's happened was also we ran across Porges about a year ago, and he's been researching what I've been trying to figure out. He's been doing this. He's actually known this for 40 years.
Mm.
So I was blown away to see what I had seen clinically correlate so deeply with what he's already done. And what it does, the polyvagal theory, and there's some serious flaws with it, which I don't want to get into right now, that we're working on with the group.
Yeah.
But the bottom line is the basic autonomic system being sort of the central conductor of this whole process is fascinating because there's bottom up impulses, there's top down impulses, there's Lisa
Mhm.
Feldman Bear's work out of New England, where the
Oh, yeah.
consciousness. Mom, you get. Have you read that book, by the way? How emotions are made.
Yeah, and that's what I wanted to ask you about later, maybe later on. So the your point about Stephen Porges and the polyvagal theory. So his argument is that we are expressing our emotions through facial expressions, and other people can interpret that, which makes perfect sense. And then we've
Right.
got Lisa Feldman Barrett, who says perhaps um, that there isn't a universal expression of emotion, and everyone experiences emotion different and creates them in the moment. How do we, then to my mind, they're not opposing, but there's a kind of a potential problem there, isn't there? That where you can get miscommunication. So if everyone has a different way of receiving emotional expressions and interpreting them, but according to the polyvagal theory, then we safety relies on those expressions. Then how do we make sure that we are receiving safe signals if they're meant to, if the intention of the person sending them is is
Absolutely.
is
Well,
for
I mean, that's something I think they're perfectly synergistic. I mean, at least I always get embarrassed. I'm a little bit orthopedic. I tend to simplify things down a lot.
Mhm.
But the reality is, as I keep asking sort of simplistic questions, I can't. They're giving me better simplistic answers. So, I mean, here's the thing. So, Porges does not like the word anxiety at all. He doesn't like any of the names we use for emotions. No, we get these sensations that reflects threat versus safety, and we put names on like anxiety. But really, that's just a big word that covers a lot of range of chemical reactions. Then my concept that get rid of the word anxiety and just use the word you know elevated sympathetic response, which
Yeah.
Porges agrees with. And the only reason I use the word anxiety anymore because it's the bridge word that people get stuck on. They think anxiety is
Mhm.
psychological. So what I've changed the language a little bit the last couple of weeks. I'm saying, look, okay, my cat has this reaction with danger. The dog comes in the yard, why she gets all reactive, and she feels something that she's now reacting to. Humans have consciousness, so we put a name on it. Then we have
Yeah.
behavioral patterns that we label as psychiatric diagnosis, like bipolar, depression, etc. What Derek Clausen has found out, and what Porges is so interested in, is this whole cytokine thing that all these disorders are the same thing. They're all inflammatory.
Right. Yeah.
You saw that stuff too. Did you ever see? There's a paper by Robert Danzer, Dantzer, out of Austin, Texas,
Okay.
2018. It's unbelievable. He just reviews the entire consciousness and immune response to the environment and
Okay.
what creates threat versus safety. And it's just even I could, he's so brilliant that even I could read it. In other words, I'm not a molecular biologist at all, but you'll love this paper, and I can send it to you right now if you want.
Great. Yeah.
But he just sort of summarizes the whole thing, and then if you chance to go on YouTube, I mean, there's those videos of the Wednesday evening meetings on the Google Drive, which I gave to you.
Yeah.
But also, if you go to just go to it's called the Locker Room, just LOCKER, the Locker Room. There's about 8 videos by D.R. Clausen where he puts all the molecular biology, the biochemistry, the input, the output all into one chart and just goes through Alzheimer's, depression, anxiety, schizophrenia. It puts it in the context of the polyvagal theory and it puts the biochemistry and the cytokines. And now he's focused on metabolism.
Right.
Then he's pulling in the complement system. And
Great.
then the guy Steve Oberman's pulling in the epigenetic type stuff. So I mean, there's a lot going on. We know this,
Mm.
but at least by getting as granular as we can, which is just a fraction of what really is, at least in medicine clinically, we're not just throwing things randomly at people. We just have some feel for what we're addressing. And we do know that at the end of the day, it's still threat versus safety. And my personal goal, if I had 2 outcomes of the Wednesday night groups, is 2 things. One of them, well, 3 things. One is the threat versus safety should come into mainstream medicine. It just
Uh-huh.
isn't.
Yeah.
Second of all, we know that in terms of threat, you have very significant physiological changes that are real measurable changes. And medicine right now is called those medically unexplained symptoms, which to me is just abhorrent.
Mm.
Your body is fired up. That's not normal.
So anything that's kind of idiopathic, if it's
Right.
described as idiopathic, it means we
There's always
don't
a
know what's
reason
going
for
on.
it, right? I
Pardon?
mean, there's
Sorry.
always a reason for symptoms. They don't just happen. So, I mean, the body just, the very second we process the environment and our body reacts accordingly. And if we're safe, we have a certain chemical makeup. If we're threatened, we have a different neurochemical makeup and metabolism. So those create physical sensations and physical symptoms.
Yeah.
Right now, mainstream medicine, have you heard this term called medically unexplained symptoms?
No. No.
It's horrible. That's the last 2 years that came out. So they think, well, since you can't see it on a test, it must not be real. And we know the inflammatory markers, the IL-6s and whatever, are all elevated in these disorders. And that's where, cardiovascular disease, peripheral vascular disease, adult onset diabetes, obesity, Parkinson's, Alzheimer's, anxiety, depression, schizophrenia, bipolar are all the same thing. And then, of course, that doesn't include the autoimmune disorders. So what I didn't realize, and all the physicians on this group on Wednesdays are sort of embarrassed, is that we learned a little bit about cytokines in medical school, just a little bit, totally ignored it.
Yeah.
We knew about the autonomic nervous system, totally ignored it. And what blows me away is that I just didn't link the inflammatory response to threat. I mean, if
Mm.
we think in terms of heart rate and sweating, et cetera,
Yeah.
we just didn't figure out the threat thing with the immune system. We also in cancer that you need an immune system, a healthy immune system to pick off cancer cells. We know also under chronic stress, people get sick and they die and they get cancer. Well, the immune system is compromised. That doesn't just happen. That's not psychological. I mean, you're dead.
Mm.
So, you know what I mean? So
Yeah.
you tell me it's the medically unexplained symptoms, we actually physically die because of sustained exposure to hypermetabolism and inflammatory reactions. So
So,
that's what I'm saying. So the goal of the group is actually to say, look, when you don't create safety for your patient, you're not addressing the root cause and you're treating these random symptoms out here that's flat out ineffective unless you deal with the root cause, and that translates into time with the patients.
yeah.
So right now we're in a production mode and we're ignoring the most incredibly basic part of being a physician is time with the patients. I know I don't have to tell this to you. So my mantra for a long time is let's just do what we know. So what I put me over the edge, we're doing T2 to pelvis fusions on patients with 6 or 8 weeks of back pain. We're doing
Yeah.
an ask what your life is like. And then, as you know, lack of sleep actually causes pain and
Mm-hmm.
change. So we're doing a 14 level high risk operation, and we're not even asking whether they're sleeping.
Yeah.
So that's where anyway, that's where I'm coming from and saying, look, just take what we know and just do it.
So basic fundamental lifestyle habit such as sleep, which I think anyone who's missed a night's sleep will know how different they feel the next day.
Right.
Normally that's not, by the time it gets to someone seeing a consultant for spinal surgery, that's not even being considered as maybe a contributing factor.
Right.
And
Or by primary care either. I mean, nobody in medicine is addressing this stuff. There's a study out of Israel that you may have seen in my reference in my book by Agmon, where they documented in over 1,500 patients in a prospective 4-year study that lack of sleep actually induced chronic back pain. And they did not find the reverse causation.
right,
I mean,
okay.
either way, I mean, I realize that chronic pain probably interferes with your sleep also, but again, it's all an inflammatory disorder. If your body's racing thoughts, your body's hyper vigilant, of course you're not going to sleep. So sleep is a symptom of this inflamed nervous system. It's also obviously a cause, it's bidirectional. So that's where I'm telling you, the last 5 years of spine surgery, instead of doing 1 and 2 level fusions that are ineffective, we're doing 8, 10, 12, 14 level fusions that not only are effective, they're just really, really dangerous. I mean, there's a 73% readmission rate to the hospital within 2 years after you have a major spine fusion as an adult. 73%.
So I guess
It's
those
horrible.
people, they've had the surgery, had the structural, um, the structural, the damage that's seen on the scan addressed. But then if they're going back to a lifestyle that was perpetuating the pain in the first place, then the pain's going to come back.
No, it's way worse than that. So these
Okay.
are normal spines. Remember, so we don't know where back pain comes from, but it's been well documented that disc degeneration does not cause back pain, zero. And then we
Okay.
also know there's not one paper that says scoliosis causes back pain, none.
Okay.
So these are normal spines for people's age. So we're doing massive, high risk, expensive operations on normal spines for people's age.
So
It's
just
horrible.
saying that again, there's no evidence that disc degeneration causes back pain.
Correct. There's one paper with the Model Association, but there's, well, in my own practice, I saw thousands of patients, I guess now, they come in for stenosis and radiculopathy, and their spines were just complete disasters. No back pain. I've had 2 back surgeries myself. I have a horrible looking spine, no back pain.
Mm.
So we saw it clinically all the time. But again, if you do a just prospective study, you just take 100 people off the street. This started in 1990 with multiple papers to follow.
Mm.
That if you take 100 people off the street that are no back pain, most of them have degenerated disc. And by the time you hit 60 years old, 100% of people have degenerated disc that have no back pain.
Mm.
I mean, I need to rewrite back and control because the neuroscience research has just exploded. But still, from a functional standpoint, it still works really well. But the one about do you really need spine surgery, again, I don't know about your practice, it's a quicker read, it's very quick. And in the
Mm.
first 90 pages, you know what's going on. You know how to make a decision about surgery. It identifies the variables into structural versus non-structural. In other words, is there something to fix or not? Then the state of your nervous system. And then based on which quadrant you're in, it's a completely different treatment paradigm. So right now, it's probably 70% of spine surgery is done on people's spines that are normal for their age. In other words, a non-structural problem and a fired up nervous system. And it can't work. The data's never said that works, but that's what we're doing in America all the time. So essentially every patient that's read that has opted out of spine surgery, and they know why they're making the decision. And when they talk to the surgeon, it makes the surgeons accountable. And it might be a resource that you might, consider
Absolutely.
pass,
Absolutely.
pass on to your patient. So I'm
Mm.
excited about it. The back end control just gives you the framework of care. It's not a 1, 2, 3 in your fixed book. It doesn't list every treatment. But my intention all the way along was to allow primary care physical therapists, different practitioners like yourself, to do their job, to unload the responsibility of chronic pain onto the patient completely,
Mhm.
and then have you just basically do your job really well, create an environment that's safe. But it, but what finally happened to me, I got so tired of trying to explain pain, and it wasn't that effective in the office setting. That's why I wrote the book. So that's why it's been powerful. It gives people a solid framework, just takes a tremendous load off your plate.
Mm.
And then it's about 90% self-directed. So it's been really enjoyable. Probably well over 1,500 patients have gone to pain-free.
If a typical client that comes across your work or comes to you, the things that they need in order to take charge of their pain themselves. So they need some education and understanding about their nervous system and what's going
Right.
on in the body. And then I saw, and that's, I guess that's the awareness parts of
Right.
I saw in your DOC journey. So you've got awareness, hope, forgiveness, and play.
Right.
The physiological or the biological understanding is the awareness. Then where does hope and forgiveness and play come in? What's that?
So in the Danzer paper, they found that there's four things from the environment that affect the inflammatory response. So one of them is a positive affect, not positive thinking, but the idea that I can do it. Number two is a sense of optimism or hope, actually changes the immune system. Number three is social connection.
Mm-hmm.
And you have to be careful because one of the concepts we learn in our workshops is that we do not let people discuss their pain ever with
Okay.
anybody. Because it's from a neuroplasticity standpoint, you actually increase the circuits that actually reinforce the pain. And then the last one's a sense of control. So it's a sense of control, sense of optimism or hope. Um, and then what did I say? It's a positive affect, which can't happen when you're angry, by the way. And then social connection, which again, social connection is really dependent on awareness. So you can't really have a relationship with people unless you're aware of their needs, you can interact in a meaningful way.
Mm.
And when you're angry, of course, it just blocks everything. And so that's why the sequence is awareness, understand the problem and the nature of the solutions. Hope is a huge deal. And it's one of the biggest factors that people just will read these stories of hope on my website. All of a sudden they say, well, I can do this. I have one guy with 20 years of chronic pain, 27 surgeries in 20 years.
Mm-hmm.
He was on high dose narcotics, suicide attempt, and he looked at the stories of hope. And with obviously using other tools and stuff, in about 6 weeks, he was pain free.
Wow.
So he's been pain free now for about 4 years now. And I talk to him all the time back and forth. But yeah, the hope thing is a big deal, mostly from a treatment standpoint to engage with treatment. Um, but also it has a direct effect on the inflammatory response.
The book which you've written, for example, is an educational tool, so it gives them the information.
Right.
But then it's that need for the social connection and the human touch and that sense of hope, which might need to be tailored for their unique story, possibly,
Right.
um, unless they can do that switch themselves and muster up that hope themselves. So
Right.
that's where I'm at really. It's how to take it from one to one and one to many, but also help people to shift that meaning, because there's a few things there, aren't there, that shift from towards optimism and positivity, hope, even forgiveness. There, it's
By the
there's
way, forgiveness is the absolute key. People cannot heal without forgiveness because your nervous system's fired up, your body's on fire, and this is all based on neuroplasticity. So we talk about learning another language. You can't learn French by trying to fix your English. You're not going to get rid of chronic pain by trying to fix it. You're going to create this new life. So positive thinking is a disaster, but positive vision is absolutely critical. So 90% of the people, I'm sorry, most people by far and away that have gotten better have never seen me. And less than 5% have seen a psychologist. It's extremely self-directed. And the fun part is so self-directed that once you start engaging, and again, there's some basic foundational steps. Once you start engaging once you flipped into this awareness mode, you actually can't turn back. So if you go to a pain clinic, they're doing things to you, sort of external, like an exoskeleton. Once you start internalizing the concepts and understand the problem, you can't go back. And so
so
the people that are
internalize.
getting
So
better and better and better over time. So things that you can do that are fun, I'll just be presumptuous here for a second, just for discussion's sake, but the group setting is powerful. And I think you saw on my website that there's a group session every Tuesdays and Thursday. Did you see
yeah,
that?
yes, yeah.
And we're having one today, 12 o'clock my time. We actually have a bunch of Europeans on it. That's why I did it at noon. So if you're inclined at all to hop on the roundtable, even if you're in the mood to participate for 4 to 6 weeks to get a feel for it, I've got one guy, Glenn, who I think is within a few blocks of you, is my guess. Glenn Smith I think is his name. He's a physical therapist, SERPA trained. Anyway, he's a wonderful addition to the group. And so he's been on regularly for now a few months, but he can give you a feel what's possible. And then in your role, things that you can do is that I'm just, again, being presumptuous here, is say that the doc journey is designed to make your job way easier and more enjoyable. because it's so self-directed, because as a therapist, you feel somewhat obligated to solve this patient's pain, right?
Uh, yeah, yeah.
So that's the first thing when I give lectures to physical therapists and chiropractors, say, stop. It's not your responsibility to get rid of their pain, it's theirs.
I saw that on the introduction to the DOC. So you're saying you're trapped, and your body, you are trapped, and your whole body and being is intent on escape.
Yeah.
So I'm quoting you here. Since there is no apparent solution for most people, the body goes into a high alert with skyrocketing stress chemicals, and you are mentally and physically miserable. So that's the situation that people are in when they're in pain.
But as a therapist, I'm assuming you've noticed that in your patients that are trapped in pain.
Oh yeah, yeah, yeah.
Okay. But see, my identity get wrapped up in you getting better. In other words, I'm the healer. I'm supposed to get you better, right? What happened, it gives you a tremendous amount of power to shut me down. In other words, if I'm attached to your
Oh,
outcome, it
mm,
gives you tremendous power to say, I mean, probably unconsciously, to just not get better. Because
mm.
if you know what I'm saying, it gives me, if my identity is wrapped up in your approval, I'm
Mm.
screwed.
Okay, say that again.
Paradoxically, is
My
it is that
my identity as the therapist is wrapped up in the
outcome?
client's identity outcome, then that
It
is a
gives
problem.
that person a tremendous power to just shut you down.
Aha.
So what happened paradoxically, I went to this workshop by David Burns about 8 years ago, and he talked about open hands. We say, hey, look, happy to help you out. I'm here. Here's some homework to do, and I'll see you back in a couple of weeks. I couldn't do that at my hospital because they wouldn't let me do it that way. But when I took that mindset that I didn't have to really help every person walk through my office, I would love to, of course, is that when I tried to get somebody better that wasn't ready, it really made them irritated. It really just triggered them the opposite direction. But I also realized it was draining my energy that I needed to help the patients that could respond. So what happened is I just let go. Probably 30% more people came back at me. Then the ones that were angry, I didn't like it, but I wasn't interacting with that energy anymore. And
Mhm,
so it would frustrate the hell out of them because I just wasn't reactive. I
mm,
felt badly for them that I couldn't get through.
mm,
But what happened is that about 30% more people came back. I'm just guesstimating that ordinarily would have just walked out the door, and it started to work. Then
mm.
the last year, when we understood the family issues better, understand the neuroscience better, can explain the whole, I think mental pain is a much bigger problem than physical pain. But
Mm.
since I've been able to couch the whole thing in changes in the body's neurophysiology, people don't argue with me anymore about, well, the pain's in my head or not. They quickly understand this is a total body response to the environment. And you can't fly a plane without a computer, and you can't run your body without a brain. So it's just a unit. And I don't like the word mind body anymore because it's just a unit response. So I use the term neurophysiologic disorder. I don't like that either because again implies it's just a unit response. That's all. So when I talk to people, I don't use terms like TMS or mind body syndrome or even NPD anymore. I talk about the body's chemical changes and how it acts and how it feels, and just negates that entire conversation. Anyways, long way of saying that by providing educational resources and then again for discussions, and let's say you give my book website or the doc journey and see you back in a few weeks. And then what you can do is listen to them, talk to them. One of the keys is not let them discuss their troubles with you, their marriages, their kids, whatever it is, that's off the table. So what
Completely
the
off the
therapist
table, or do you let them start for a few minutes and then change the subject?
just, well, I mean, probably the first visit, you have to hear them out. I mean, I'm sorry, people need to tell their story once. I think that's
Yeah,
fine. But they come in and they complain again and again and again, right?
some of
Okay,
them.
so as you listen to the story, you can empathize. I mean, it's really critical to establish a relationship. I get it.
Mm.
And then, might give them some homework to do. Look at my book or some of the material you put together, and then start structuring the therapy sessions with the idea that a whole idea is to help calm you down. By the way, if you're complaining about your marriage, that doesn't calm you down. So the
Mm.
type of music, the touch, to say this is a huge opportunity for whatever time you spend with them to
Yeah,
really teach you the tools to calm down your nervous system.
yeah.
Which I know you already do that, but what
But
the
helping them.
doctor does, it takes a whole bunch of stuff off your plate that you don't have to deal with, and so then you can just keep your energy up for the. So anyway, what I segued by, so I learned by just letting people go that I couldn't help. In fact, the harder I tried to help, the worse it got. that I preserve my energy or conserve my energy for people that I could help.
Sure.
Completely changed my practice. Huge.
Mm. So if I'm to hear that, then so if when people come to you, then you're able to see a story that they are running over and over and over again, whether it's a family relationship or their job or whatever, then you shine the light on that story and say and help them draw the correlation between that
Mm-mm,
and the pain. No.
nope. See, the approach I take is change level. It's not startup stuff. I mean, I realize that works to some degree, but it takes energy. And I don't do any counseling at all.
So
So I
how
give
do they
people,
how will they learn that that is going over that scenario is contributing to the pain and the inflammation and the state of their body? If
so the reason I put the doc journey in the sequence is awareness, hope, forgiveness, and play, is that they figure it out. In other words, it's in their own
okay,
awareness, they'll start figuring this thing out. And so I say, look, I just want to teach you tools to help calm down your body's response to the
right,
environment. And then we talk about how the inflammatory response occurs. When I was talking about the polyvagal theory, is that just these breathing exercises or things that you do directly stimulates the vagus nerve. They go, oh, okay. So in your sessions, again, I don't know what your sessions are like, it allows you to practice breathing techniques, listening to music. They feel tension, where is it being felt at? And what I don't do is that I'm not a counselor.
mhm,
I say, look, I just want you to do some homework, just learn about the process, and don't try to fix anything. So I want them to learn the model and ask them to start the expressive writing, which has been very powerful. I think you saw there's a book out that you really want to look at called Opening Up by Writing It Down. And
okay,
it documents, there's over 1,000 research papers that documents effectiveness writing. I don't give this to them, but for you personally, it's like just hundreds of references in the back.
great,
So I do get them started in expressive writing. I do a little bit of meditation work. There's a friend of mine, Les Aria, who you'll meet on the roundtable, who does this little heart rate variability monitor on the forehead. And he's breaking people's 10 years of chronic pain up in 15 minutes. It's ridiculous. I mean, he's amazing.
I mean, I use the Heart Math Institute's EM
There you
wave.
go. One of the key factors of the Doc Project that's very paradoxical is that you look up a website post called The Ring of Fire. Have you seen this yet?
I saw you refer to it,
Right.
yeah,
So there's a green center, which is safety, contentment. Then the red ring is anxiety, frustration. Then the blue ring on the outside is life. And there's a tendency, especially myself, that we should be living our life a lot of the time in the green ring. And it's a trap
mm,
because life's the whole circle. So
mhm,
every new relationship, day, paying bills, whatever, all has a little bit of anxiety involved, sometimes a lot.
yep,
And so, what the goal is, if I want to call it a goal, is to use the tools to regulate your body chemistry. So, it doesn't matter what the triggers are, you learn things to calm down, or you can change the input or work on the output or calm the whole nervous system down. But there's different intervention points. And what you're doing is based on awareness. So, I'm in a little bit of the red ring. So, I can be in that for a while and it's okay. I can jump into the blue from there or I
mhm,
can go back into the green and regenerate. But the goal is to be aware what color you're in and then negotiate the entire circle on your own will. And what happens, I was trapped in the blue trying to outrun the red, which didn't work. And then I really get this obsession about being in the green all the time. And people they get trapped in the green because they don't want to have anxiety and frustration. But as you learn to process it on a regular basis, minute by minute, day by day, it happens all day long. Things change dramatically and you're free.
So it's so then to summarize that, it's not a problem to have fluctuations in how we feel day to day. It's making sure we don't get trapped in any one of them for too long, or get anxious about being in one of those zones.
Well, right. You get anxiety about being anxious. So the key issue, and Freud said this in the 1880s, that the essence of mental health is being okay with uncomfortable emotions. You've heard the saying, what you resist, what you resist
Resist,
persists, I think
persist.
it is.
Mm,
Right. So it's a whole, not thinking about white bears analogy, as you well know. So it's one of those things where if you're anxious or frustrated, see, my problem, being a surgeon, I'm a perfectionist. And so I get into this emotional perfectionism stuff. So if
right.
you're anxious or frustrated, I think I should sort of be above that, right? And I'm actually working on it right now at a lot of different levels, different techniques. And so my whole approach to the doc journey is paradoxical. In other words, The source doesn't matter. You become aware that you're fired up, and you make a choice to stay there. Just understand it's your choice. And you can't control anxiety and anger, but you do have a choice about using the tools to go to a different color. So if you want to stay in the red ring for a week, that's okay. Just be aware that's what you're doing.
Right.
You haven't got to this part, but so that's why the forgiveness part is so critical, because we know from consciousness that if you're linked to, 90% of people in chronic pain are still pissed off at the person or situation that hurt them.
Yeah.
So we know that mental pain, or should I, mental threat, has the same effect as a physical threat, but of course, mental threats sustain. People get better without forgiveness, but they don't heal. They just cannot. And so forgiveness is a very selfish act, has nothing to do with religion. It's just saying, I'm taking my life back. This person I dislike is no longer going to be in my head every day. So you can't suppress it, and you can't, quote, accept it. And this Fred Luskin wrote this book called Forgive for Good. He's a good friend of mine. You process it. So I get upset 5, 10, 15 times a day. So at least I'm aware I'm upset. And then again, I'm working on being upset about being upset. That's my other issue. But yeah, it's just a second by second, just dynamic relationship with the environment. And pretty becomes pretty automatic.
For a client or someone who's not heard that term process used in this setting before, what does that mean to them? What does process, is process equivalent to forgiveness, or is there, somatics and play? Does that help process? What's the...
Well, I use it in terms of tools. In other words, okay, I'm angry. Okay, so what doesn't work is positive thinking and suppression. We know that. Okay. So Fred Luskin presents about 6 or 8 different tools about how to process the input. But when you do your breathing techniques and what you're doing, you're working on the output. In other words, your body's inflamed, you're pissed off about your boss. So maybe you can figure that out, maybe you can't. It doesn't matter. But just this is slow breathing, drop it down, do some expressive writing. Whatever it takes to drop down the inflammatory reaction, you've actually dealt with the anger. Now, dealing with the input is a different story. And again, Fred Luskin has pointed out there's never a beginning or end point to forgiveness. This is a day-to-day process to become aware you're angry. And what DeMello points out, this little book called The Way to Love, I don't have it here in front of me, which is a little meditation book. He just calls it right out. It's just a lot of the people on my roundtable, by the way, and myself included, are thinking that just awareness is enough.
Okay.
By becoming aware of the disruptive nature of this situation, you go, well, that's sort of ridiculous. Why am I letting this bad parent 30 years ago bother my day to day? I'm just gonna pretend you're my patient for a second. So I said, look, when you walk out of the door of my office, you are never simply never going to discuss your pain ever again, or medical care. Anybody except your providers. Second of all, no complaining, no gossiping, no giving unasked for advice, no criticism, because where do you want your brain to develop? Because that's where it's going to develop. And guess what? It's really hard for about 2 weeks. And then people start getting it, and it is the expressive writing is ridiculously powerful. In fact, I feel a little guilty about it. It's sort of the secret weapon. But not discussing the pain has been equally as powerful. It's been amazing. So yeah, just breaks people out of these behavioral patterns and gets them moving forward. So yeah, if you get a chance to hop in the groups, you'll see a different format than you've seen before. We've held these workshops where this came about, where we figured out that I didn't realize that people in chronic pain talk about their pain all the time. And I think you saw from my book that I was in chronic pain myself for 15 years.
Yeah.
And I was an epiphany addict. You just want to get out of it. So of course you're going to talk about it. And so I just get so much worse. It was unbelievable. Anyway, so I got to run. So I'd love to follow you up in a couple of weeks to see how it's going. I'll make the introductions for you. And do you have the new link? I didn't give it to you. We have a new link for the Zoom meetings as part of the doc. Did I give it to you as part of the doc journey? We changed it.
I'll check.
I'll send it right this second. When I send these introductions here, I'll just do all right in one shot.
Thank you very much. Wonderful.
Thank you. All right. Well, I'm excited to get a hold of me, and I'm excited about where you're headed with all this. And if I can help move that along, I would love to do that.
Likewise. Thank you for your time. Thank you.
All right. See ya.
Bye-bye.